My presentation is on depression in adolescents. Also known as major depressive disorder, major depression, or clinical depression causes symptoms that impact how a person thinks, feels, and goes about daily activities. To be diagnosed, depressive symptoms must be present for 2 weeks. Types of depression include major depression, which involves symptoms of loss of interest and depressed mood for most of the time for 2 weeks, which interfere with daily life. Persistent depressive disorder involves less severe depressive symptoms that last for about 2 years. Perinatal depression is depression during or after childbirth. Depression during the pregnancy is prenatal depression, and depression after the birth of the baby is postpartum depression. Seasonal affective disorder is depression related to the seasons. So, for example, during the winter, an individual might experience more depressive symptoms. Depression with psychosis is depression with symptoms of psychosis such as delusions or hallucinations. In 2021, around 5 million adolescents, which is about 20.1% of adolescents in the US, had at least one major depressive episode. The prevalence of major depressive episodes was 29.2% for females and 11.5% for males. Rates of depression in adolescents have increased from 8.1% to 15.8% from 2009 to 2019. If you click the link, there is further data about the prevalence of depression, with trends of depression too. A study found that adolescents who had a depressive episode were more likely to have one 15 years later. So 75% of adults with major depressive disorder had an onset of depression during childhood or adolescence. Those in the LGBTQ+ community are at a higher risk for depression. Risk factors for depression include a personal history with depression or a family history of depression, and major life changes that are negative, stress, or trauma. A Chinese study found that adolescents' perceived stress was related to future depressive symptoms. Having emotionally unavailable parents, high marital conflict in parents, parents with financial problems are linked to adolescent depression. Children whose parents have depression are 2 to 3 times likelier to develop depression than compared to children whose parents have no history of depression. In 2021, around 40.6% of U.S. adolescents with major depressive episodes were treated, and for those with severe impairments, 44.2% received treatment. Men are more likely to seek treatment for physical symptoms of depression rather than the emotional symptoms. Depression that's treated earlier is more effectively treated. Depression can be treated with psychotherapy, medication, or a combination of the two. Adolescents are usually poor at recognizing depression, and depression is often linked with stigma. In a study, adolescents were more likely to be depressed during COVID-19, however, exercise did help. Incidences of depression have increased during adolescence, as I said earlier. Cognitive changes such as enhanced cognition in the concrete operational stage, where individuals can think abstractly and think more about themselves, increase adolescents' vulnerability to depression. There's a link to more information about the concrete operational stage. Adolescence is a time where cognitive vulnerabilities are likely to happen. Cognitive vulnerability is the presence of a self-schema that is maladaptive, which has themes of unlovability and helplessness that become activated by negative moods or negative life events. During adolescence, adolescent individuals experience adolescent egocentrism, which is a heightened level of self-consciousness with the imaginary audience and the personal fable. Many cognitive vulnerability theories of depression causes use a vulnerability stress paradigm where cognitive factors and environmental factors interact to increase the risk for depression and other disorders. This is bidirectional because symptoms of depression predict increases in events being perceived as stressors. The attributional style is one cognitive vulnerability factor where depressed individuals attribute negative events to global, internal, and stable causes. Viewing negative events as external, specific, and unstable is an adaptive style which can be a protective factor against depression. Life events and attribution style are stronger predictors of depression as children get older. For example, adolescents who have a negative attributional style when they were younger continue to have a negative style. However, it is suggested that attributional styles are a mediating factor in associations between stressors and depression. The reciprocal model posits that as depression is more severe, attribution styles are more negative. Developmental psychopathology model posits that cognitive, social, environmental, and self-regulatory factors related to depression influence each other. Also, a competency model posits that negative events in life causes maladaptive self-cognitions, which can be a predisposition to depression. The cognitive control network comprised of several areas of the brain shows increased activity in depressed adolescents. As you can see, there's a link to a video more about the adolescent brain, and then the picture talks about how the adolescent brain is more sensitive to stressors. Girls tend to face more discrimination, which can cause higher rates of depression. Also, girls go through puberty before boys do, and those two reasons could be why girls experience more depression compared to boys. Adolescent depression is associated with having other mental health problems, lower educational attainment, and problems in relationships. School is an arena for social and emotional development, but it can foster negative life events. Children 5 to 9 years old whose teachers felt were more likely to experience peer rejection are more likely to be depressed during adolescence. Bullying predicts symptoms of depression, especially for girls. Peer bullying is a strong risk factor for depression. During adolescence, peer relationships are more important than parental relationships. Therefore, social exclusion is really felt during this time. Adolescents value intense and intimate friendships, and the close friend quality of adolescence was a predictor of depressive symptoms. Research during adolescence shows that social support from friends is associated with higher levels of physical activity, which has been shown to prevent depression. Young people have the highest rate of loneliness compared to other ages, however. If adolescents do not have close friendships, they experience decreased self-worth and loneliness. Studies have shown that loneliness and depression have a bidirectional association. Studies have shown that consistent peer-related loneliness in childhood predicts depression in adolescence. Another study showed that after COVID-19, with an increase in social isolation, there was an increase in adolescent depressive symptoms. During adolescence, individuals enter into romantic affiliations, explore romantic relationship, and consolidate didactic bonds. However, a study showed that adolescent girls who have an older romantic partner are more likely to have depressive symptoms. Problems with romantic entanglements can cause depression in adolescence. Also, a study found that autonomy supportive parenting was linked to positive adolescent psychological development, and autonomy controlling parenting was linked to an increased risk of psychopathologies. So as I mentioned in the previous slide, girls are more likely to have depression, and one reason for this is because girls tend to ruminate more than boys, and they amplify it. Also, girls' self-images are more negative than boys' self-images, which could be associated with an increased risk of depression. Being stressed about weight is theorized to have contributed to more girls having depression. The photo, you can see the rates of depression between genders, although I did talk about it in the first slide. Mother-daughter co-rumination is linked to increased rates of depression in girls too. Adolescents who are depressed show more emotional regulation difficulties, selective overattention to emotional stimuli that are negative, and ruminative self-scrutiny. So hot executive function, emotionally driven psychological processes peak at 14 to 15 years old and declines. Attachment theory posits that adolescents who are insecurely attached have an increased risk of depressive symptoms via emotional regulation strategies that are maladaptive. Emotional regulation involves modulating, evaluating, and monitoring emotional responses and encompasses responses to positive and negative effects. Study results show that anxiously attached adolescents did develop more symptoms of depression due to increased rumination on negative effects and a decrease on positive effects. Adolescents who were avoidantly attached developed more depressive symptoms due to decreasing their focus on positive effects. So, securely attached children were more likely to seek help when they were distressed and use parental help to regulate their emotions. Also, securely attached children had more modeling of positive emotional regulation from their parents. However, insecurely attached adolescents did not seek support during distress and had less adaptive emotional regulation skills. So, a study found that insecure attachment was linked to adolescent depression. So parents who engage in positive parenting practices have adolescent children who are more likely to disclose information with them. A review found that cognitive behavioral therapy and family therapy can be effective for treating depression in adolescents. The link is to an article which discusses some of the therapeutic orientations that there are. Additionally, SSRIs, which are selective serotonin reuptake inhibitors, are found to be effective. However, SSRIs are associated with an increased risk of suicidal ideation. The picture is how SSRIs work. For some, a combination of therapy and medication is beneficial in treating depressive symptoms. Other treatments can include lifestyle management, so changes in physical activity, dietary patterns, and sleep patterns, and also addressing contributing factors of depression. Practitioners are encouraged to prioritize depression screenings for adolescents. As female adolescents and adolescents from Asia, Africa, and the Middle East are at a higher risk of depression, practitioners should create gender-specific and culturally relevant programs for intervention. For example, considering girls tend to face more discrimination, which can cause higher rates of depression, feminist therapy could help in improving outcomes for women. Being able to resist sexist attitudes positively contributes to the mental health of women. Feminist and critical consciousness therapy orientations emphasize how power dynamics, oppression, and privilege shape well-being. Feminist therapy promotes empowerment, which can improve well-being in women. A study has shown that an increase in feminist action commitment and empowerment was linked to a decrease in depression. Because the onset of depression during adolescence predicts a trajectory of depression depressive episodes in the future, identifying positive modifiers in symptomology is important for developing preventative and treatment strategies applied early in life before depression onset. Sleep is a potentially modifiable behavior because it changes during adolescence and is important for brain plasticity. A reduced amount of sleep during depression increases the chance for depression. So improving sleep in adolescence could build on neurodevelopment to improve brain plasticity and less neural vulnerability impacts to depression and reduces the risk of depression. The link is an infographic about sleep in childhood and adolescence. Selective prevention identifies individuals with depressive risk factors, and prevention programs for individuals whose parents experience depression have been found to be effective. Increasing protective factors can reduce poor outcomes and thus the risk of depression. Such protective factors include a positive attributional style and social support. Also, a study showed that improved peer acceptance, dependability, and making new friends was related to a reduction in depression. School-based programs can include all members of the school who are, or all that are high risk, or those with subclinical disturbances. A study found that psychological preventative interventions in school can prevent depression universally. So, in conclusion and review, 5 million adolescents have depression. Risk factors include a family history of depression and adverse life events. Depression in adolescence is associated with having depression in adulthood. The cognitive changes in adolescence increases this age group's vulnerability. Attribution can be a factor in depression during adolescence. The depressed adolescent brain has differences in activations. Girls are more depressed potentially due to more discrimination that they face. Bullying and lack of peer connections can be a risk factor for depression. Depressed adolescents have emotional regulation problems. Insecurely attached adolescents have a higher likelihood of being depressed. Depression can be treated using therapy, medication, or both, but early screenings and preventative measures can be effective in preventing depression. So on the next 2 slides are my references. In the notes section of the PowerPoint is where I got all my information from. All the sources are listed there as in-text citations, and that's the end.